Okay, so for class 2 antiarrhythmics, the big ones on here are going to be the beta blockers. Okay, so I just put a bunch of them on here. I don't want to go into too much detail just for the sake of time because this is kind of a longer video, but just remember that beta blockers are going to inhibit the CAMP cascade. So they're going to inhibit adenylate cyclase, they're going to decrease your CAMP levels, they're going to decrease intracellular calcium concentrations. That's the bottom line, right? So if I decrease CAMP, that is going to decrease my calcium levels. Now, again, if I'm talking about the SA node and the AV node, right? These are my pacemaker cells. Remember, the calcium is primarily going to be used, specifically the L-type calcium channels, right, are going to be used for phase 0, right? That's primarily going to be your depolarization. And then some components of the later stages of phase 4, like we talked about in the previous video, but mainly phase 0. Okay, so when you do that, right? So when I give somebody one of these drugs, instead of their curve kind of looking like this, right, it might look something like this, right? It might take longer for me to get to that depolarization, right, because I'm delaying this phase. So when I'm delaying this phase, right, when I'm delaying phase 0, that's going to decrease the heart rate, right? That's what beta blockers do. Now, the other thing that they're doing, right, I'm decreasing my calcium intracellularly. What's that going to do in ventricular myocytes, right? In my ventricular cells, if I decrease my intracellular calcium, I'm going to decrease my contractility, right, because of calcium-induced calcium release. And we have an entire video talking about how this works exactly. I don't want to get into all the details, but it really has to do with the ryanodine receptors, right? And then binding that will induce calcium release from the sarcoplasmic reticulum. Okay, so that will decrease contractility in the ventricular cells as well. Now, if you're slowing the heart rate through the SA and the AV node, if you're slowing this conduction, it's going to take longer for the signal to go from the atria to the ventricles because you've delayed your signal here. So when you delay that signal, that's going to give you PR prolongation, the amount of time from atrial depolarization to ventricular depolarization. Okay, and again, we just said prolonged phase 4, right? You're going to get a little bit of a prolonged phase 4, but you'll also get a prolonged phase 0 in the pacemaker potential. In general, another thing to remember here is the AV node is particularly sensitive to these beta blockers, okay? So that's where some of this PR prolongation comes from. And another thing to remember is if you're in a board question and you're trying to decide between medications, remember that there's a lot of side effects you want to consider when you're talking about, beta blockers. So if we're talking about beta blockers, okay, I like to think of things in 3. Okay, so what are the big 3 diseases you want to be aware of that you do not want to be just throwing beta blockers at? The first one is going to be asthma and COPD, especially if we're talking like non-specific beta blockers. The other one is going to be if a patient has recent cocaine use. So in these patients, you can get the unopposed alpha-1 stimulation, right? If you just block all the beta receptors, the cocaine can just activate the alpha receptors and you get this very, very high blood pressure. Remember, you can actually use labetalol and carvedilol in these patients because labetalol and carvedilol are non-selective alpha receptor antagonists, but also beta antagonists. So you wouldn't get the unopposed alpha-1 stimulation with cocaine use in those patients. And also, just to put as a side note, you can also put pheochromocytoma here as well for the same reasons, right? Because of the sympathetic stimulation, you block beta receptors, you have unopposed alpha. The last thing is, remember, if a patient has hypoglycemia, by giving them a beta blocker, you can actually mask the symptoms, one of the big ones being tachycardia. Okay, so these are the big things to kind of keep in mind when you have a board question with beta blockers. If you're deciding between some of these drugs and you're not sure which one to pick, beta blockers, just be careful. If you have to make a decision, look for asthma, COPD, cocaine use, VO, or hypoglycemia. Really big things to keep in mind. If you know that beta blockers act at the AV node, right? We said there's a really kind of strong connection with beta blockers acting at this particular site, causing PR prolongation. Do you want to give a drug that causes PR prolongation to a patient that has AV block? What's the problem with an AV block? Well, you're not getting the signal through the AV node, right? A first degree AV block, what's the sign on EKG? It's PR prolongation. So you don't give beta blockers to patients that have trouble getting their signal from the SA node down to the ventricles, that being through the AV node. Okay, that's the point.